Gite sir. Dr. Gite.
Sir.
So,
sir, good evening,
first we take one instrument,
yes,
the saying ureteroscope.
Ji.
Hiren is there, Hudedar is there. Pankaj will be joining little late.
Okay.
So
Good evening,
after
sir.
that, your friend, professor of pharmacology can join and will teach. And then we will take RIRS or other instruments after that.
Okay, sir.
So 15 to 20 minutes. First, we start with instruments. So we wait for 2-3 minutes.
Yes, sir.
And we start. Okay.
Yes, sir.
And you are doing extremely fantastic work in
yes, sir.
making our Maharashtra group.
Same here, sir. Very good, sir.
Sir, ये आपके गाइडेंस के सिवा पॉसिबल नहीं सर.
नहीं, but extremely good. एकदम बहुत अच्छा, and it is working out so well.
Proud of you, sir. Proud of you.
Yeah, it will be one of the best association. It should come out as that.
Good indeed.
Yeah,
हाँ, हिरन भाई, लेकिन सर का बैकअप के सिवा कुछ नहीं होता.
वो तो है सर, बट हम लोग है ना आपके साथ एकदम जोड़ के फेविकॉल का जोड़ लगा दो.
सच है.
सर आपके पीछे और मैं सर के पीछे हूँ.
नहीं, हम सर के पीछे है, ऐसा बोलो.
मतलब सर का सपोर्ट है आपके लिए.
यस.
अच्छा, Gite sir, there is one question. कि भाई उन लोगों ने exam they had given in June month, and now 4 months are almost over. So what is your what is an update? Can you just tell the students?
Tentative practical
whatever you
exam.
know.
Tentative practical exam of DNB, which is in the 2nd or 3rd week of November. Because they are searching for the centers, and the primary aim of giving the center is the center where the MCH program is going on.
So they get a good patients and good backup.
They will initially try with that, and if they will not able to get such test centers, then they will shift to the private.
Because their idea is probably that instead of DNB center, they want MCH center, so that like any favoritism or something cannot take place. Probably that must be in the idea. And the second thing is that they will get a good number of patients.
इतने सेंटर शायद नहीं मिलेंगे सर, तो they have to change their policy, because it's difficult to get such big.
No, not only that, even the MCH center colleges may not be keen on holding this exam because they are already holding their MCH exam. It's quite a tedious work, so they may not accept also.
हाँ, तो that may be true sir. थोड़ा सा आज भी because क्या है कि थोड़ा मैं इधर आने की वजह से we are losing the chance probably.
Yeah, otherwise you would have got it in JJ. They already wanted in JJ.
100%.
Dr. Gite is, you can imagine Dr. Gite as your examiner in JJ. Nothing can be better than that.
That is true, sir.
Yeah. I think 33 already have joined. So
we will start, sir.
We'll start, correct? Paras?
Yes, sir.
Are you with us?
Yes, sir. I'm.
Yeah.
So
first, you start with URS things.
Sir.
Sir, answering question, sir.
सेंटर नहीं भी मिला तो आप एग्जामिनर रहने वाले, कोई चिंता नहीं, आप और मैं तो दोनों रहेंगे.
बस.
Sir, who will be answering today?
Who is answering today?
Sir, me, sir.
Ojas, sir. One by one.
Ojas, sir.
Okay.
Yasir, sir.
Who is that? One is Ojas.
Yasir,
who
sir.
else is answering?
Sir, Yasir.
Yasir. Any new candidate? Yasir and Ojas, apart from that? Anyone is willing? Can you raise the hand? No one is there? Ojas, last time I told you.
Yes,
you
sir.
point
Actually,
out-
I have told some candidates, but they're saying they will present next time. Yes, sir.
Next time is always going to be the next time. It will never be the present time. No problem. Okay, fine. So let's start. Okay, we'll start with Ojas with you.
Yes, sir.
Fine. So let us
This-
start from the right hand side. Can you see the
Okay.
right hand side
Yes,
instrument?
sir. Yes, sir.
Okay, tell us.
This is a semi-rigid ureteroscope, Marburger type offset lateral piece with the size I would like to see with a Marburger type offset lens with one with inlet and outlet channel, the light holder, and a single working channel with a washer, and there is another. Sorry, there are two working channels. And it is yeah, and then there are two inlet and there are two channels that's for the inlet and the outlet. This is yes, sir. I'd like to see this would be this is Carl Stores. Yeah, I think it is Carl Stores. So it is Carl Stores semi-rigid ureteroscope, Marburger type eyepiece, and with two working channels.
Okay, Rajesh Kumar, I think wants to
Wolf
answer.
it is written.
Rajesh, can we unmute you? Just unmute Rajesh Kumar.
Hello,
No,
yes,
it is
sir.
Wolf. It is Wolf.
Wolf,
Yeah.
Wolf, it is written there.
It is Wolf. Yeah, okay, it is Wolf. Sorry.
Yeah. Okay, Rajesh, you answer this time. Huh?
Okay, sir.
Okay.
Simple point was just for identification of wolf or stores
Yes, sir.
is that the rubber seen behind is always
Pink color.
red,
Pink
pink
color.
or red color in the wolf, and it is a black color in the wolf. Stores.
Stores.
Okay. Okay.
So it is a flat one and then normal, like your cystoscope, you will get it. Okay.
Yes, sir.
And
Yes.
sometimes
Also
it
in
may
the
be
wolf,
made up
it
of
is
a
attached.
metal also.
T-shirt दे दिए थे
Yeah.
वो.
We don't
In
have
the-
any stores. If you can get it from the net, Paras, just show them. Okay.
In the wolf, the channel is attached with the scope. In stores, it is you can fix it from behind.
So you should know at least 3 to 4 points. Rajesh, you know any difference between wolf and stores?
Yes, sir. The eyepiece is in this wolf type is offset type, sir, and that of a storage and in a storage is like a straight one and a oblique one, sir. The other thing is in the size of this, sir. The minimum size in the wolf is coming 4.5 to 6.5, sir. And in the storage type, it is starting with the 6.5, sir. 6.5, 7, sir.
No, stores would
And-
come with 4.56 as well.
I don't think so, sir.
It comes.
The minimum is 4.5 and 6. This is of wolf, sir. And
The car
inlet
stores will come with
outlet,
4.5/6. So I have
in
seen
the
at my
straight line.
institute,
This
sir.
also.
Actually, car stores will come with 4.5/6.
I don't think so. For car stores are making 4.5. Maybe.
No, stores is always of 7 French or 8 French integrated or 9.5 French or 9.5 French rotoscope of stores. And for wolf, Rajesh Kumar is telling it is 4.5 by 6.5, 6, 7.5, then 7, 8.5, and with 8, 9.5 ऐसा.
Hello,
So
Gite sir,
small-
can you please repeat, sir?
Wolf is, sir, Gite sir, I will tell. Wolf is 4 French, 6 7.5, 8 9.8, and 12 French, the old one.
Okay.
Carl's stores is 6 French by 7.5.
So please, all of you remember this. This is the first thing. Second point is, as Dr. Hiren Sodha has said, you have a bridge in the most of the time in the Carl stores, and this is integrated. Third point is the nipple. Okay, in Carl stores, many times there is a valve and there is a metal at the end. Okay, so these are the
Yes, sir.
three different points.
Sir, plus
Fine.
in the stores, this tapering is stepwise, wherein the Wolf, all the scopes come as the stepless.
Okay, so that is a fourth difference.
Yes, sir.
Yes.
Yeah. So what are the uses?
So the uses of the ureteroscope can be divided into diagnostic and therapeutic. Diagnostic would be to identify any any ureteric pathology in the form of any mass or any growth, to obtain access in the ureter, and then to do an RGP. It can be used as well if you want to. I think that could be one second. Third, the therapeutic could be for ureteroscopic lithotripsy, for initial access, to put a safety wire and obtain access to the pelvic access system before doing a flexible scopy. Then it could be also used for doing endopilotomy, or endopilotomy or laser endopilotomy, and it could be also used for this management of endoscopic management of strictures in the upper or the lower part by using these are the uses.
You have forgotten about the stone, the most important.
It's a stone, I said, it's a ureteroscopic lithotripsy. Yes, sir, I said.
Okay, fine.
Yes,
And what about a urethra?
Urethra, in case of a very narrow urethra where a 6 to 17 French sheath would not be admitted, a ureteroscope could be used to negotiate a smaller passage and insert a guide wire into the bladder, so that would use as an access to do optical interurethrotomy. So to obtain initial access using a ureteroscope and putting a guide wire, and then using OIU to as a guide, so as we can do a urethrotomy.
What else?
Sir, in the pediatric cases, sir, we have used in the bladder stone also, sir.
Correct. Pediatric. That is one. So in pediatric, what are the uses?
Pediatric, it can be also used to
Apart from all these things, ureteric stone, then redo PCNL from the this one antegrade, sir.
Start from below, na, beta. First of all, you want to do diagnosis, so you want to do whether there are posterior valves. So you can do fulguration of posterior valves.
posterior valve can be, yes, sir.
Then, if required, in a Marion's disease, hypertrophic bladder neck, with that you can, fulguration of or cutting of the bladder neck also in some cases. Then, what else?
So can we say about just asking, sir, can we comment on the seminal vesiculoscopy or no? We cannot. Or,
In adults, if it is, yeah.
in adults.
One day I will show you. I had done it.
Okay.
But it is very rare,
Okay. We
in
should not
20,
say
30
that.
years, you may come across one case. So that is very, very rare.
Okay, sir.
Fine. Then in Bachus, in children, you can use as a nephroscope also.
Yes, sir.
Yes.
Fine. Okay. Hiren, Gite sir, उदेदार जी, आपको कुछ ऐड करना है?
नहीं सर, नहीं.
Okay. So how we are going to use it? Rajesh, can you tell us?
Yes, sir. First of all, after all the aseptic precaution, we use routine cystoscopy before using. After putting a jelly and all the routine cystoscopy, we will.
You are talking about the ureteroscopy for a stone, correct?
Yes, sir. Yes, sir.
Right.
And after putting a guide wire, we used to over the guide wire or side of the guide wire, we used to put a ureteroscope. We'll examine the urethra. Then after we'll examine the VUJ portion. Then we will enter into the ureter. If any.
Rajesh,
Yes, sir.
after doing the cystoscopy, why you are doing the cystoscopy? First
Sir,
aim of the cystoscopy is to know the path, infravesical path and intravesical
Yes, sir.
configuration of the ureteric opening and any abnormal finding in the bladder.
Yes,
That is the purpose of doing the cystoscopy initially. And when you are, in some cases, there is a need of RGP.
Yes, sir.
To again assess the path of the ureter. So this is the purpose of
Doing
doing
the
the cystoscopy and placing the guide wire across the pathology in the ureter, if it is required. Okay.
Yes, sir.
So what
Yes, sir.
then the next question is, what are the configuration of the ureteric opening? Some are oblique, some are globular, some are oval, some are stenotic, some are patulous, some are golf hole like. So these are the after seeing such type of opening, you can judge in the dilatation of ureter or ureteric opening is required or not. That is the just judgmental. So confirmatory nahi. True. Then after placing the guide wire, you told ki you will place the ureteroscope aside of the wire. Then how will you decompress the bladder?
Sir, before when we put the guide wire through the cystoscope, that time itself will decompress the bladder, sir.
And after that, you don't need any decompression.
Yes, sir. We used to put an infant feeding tube, but after putting a ureteroscope, sir.
How will you place ureteric feeding tube with ureteroscope in situ?
Sir, along the
ureteroscope
side,
अंदर रहते हुए भी feeding tube कैसे डाल पाएंगे?
sir, along
No,
the
can I
side
answer?
of the.
Sir, can I answer?
नहीं उसका क्लियर होने दो.
Okay.
देखो यूरेट्रोस्कोप अक्रॉस द
Sir,
ब्लैडर नेक है, तो उस यूरेट्रोस्कोप के बाद उसे फीडिंग ट्यूब कैसे जाएगी? How feeding tube will go inside when there is ureteroscope is there?
Rajesh, you can always correct yourself. You can tell sir that I will put feeding
Sir,
tube and then start with the ureteroscopy.
Yes,
No,
you have to place feeding tube first.
yes, sir.
correct
Okay, and
yourself.
then
No,
pass the ureteroscope.
Yes, sir.
Go ahead. आगे बोलो. Ureteroscope अपने अंदर डाल दिया. आगे बोलो.
Sir, after inserting the ureteroscope
No,
through
Rajesh,
the
Rajesh,
through
one
or by
second.
the SAS. Yes, sir.
Rajesh, in female, it will maybe
Yes.
you may be able to put the infant feeding tube after putting ureteroscope, but in a male,
Yes,
it is little difficult. It is not impossible,
Yes, sir.
but it is difficult.
Yes, sir.
So always we like to put infant feeding tube first, and then we insert the ureteroscopy. Okay,
True, sir.
Yes, sir. Yes, sir.
fine. Okay, go ahead.
Sir, after reaching the this ureteric orifice, either we can go by the side of the guide wire or as a path through the guide wire, sir. We will enter the ureter. We will examine. Then we will examine the whole length of the ureter, and if a stone is there, we will break the stone either by the lithotripter or by laser. Or if any a structure is there, or if you have to place a DG stent, we will push, we will pass through guide wire through the ureteroscope and put a DG stent through the itself.
Okay, Rajesh.
Sir, can
Yes,
I
sir.
answer?
हाँ, नहीं उसको बोलने दो. Because you are already there every time.
Yes, sir.
उसको बोलने
Yes,
दो.
sir. Yes, sir.
कोई इशू नहीं. So after placing the ureteroscope, after introducing the ureteroscope inside the bladder, okay. So your
Yes, sir.
one wire is already across the your pathology. It may be stone, it may be picture. Correct?
Yes, yes, sir.
Yeah,
Yes, sir.
wire may go, wire may not go. Then
Yes,
how
sir.
to negotiate the wire? That is a different question. Wire नहीं जा रहा तो क्या करें?
Yes,
तो
sir.
उसका भी अलग अलग ट्रिक्स टिप्स एंड ट्रिक्स है वो पढ़ लेना क्योंकि पूछ सकते हैं. Then
Yes,
how
sir.
to negotiate the ureteric opening with ureteroscope. Again उसके भी कुछ टिप्स एंड ट्रिक्स है वो एग्जाम में पूछ सकते हैं. नेगोशिएट नहीं हो रहा तो फिर विवेलिएंट कैसा ऊपर करने का, how it follows the enter wall of the ureter and it will enter inside and then re-rotate. This is one
Yes,
of the
sir.
technique to enter inside. And if ureteroscope is not going, then dilatation with small size ureteroscope, dilatation with ureteric catheter, ureteric dilators, balloon dilators, वो भी पूछ सकते हैं. फिर balloon dilators का कहाँ वो मार्क रहता है कितने सेंटीमीटर को, वो भी पूछ सकते हैं. उसके बाद में after entering inside, the identification of the pathology, that is stone, then stone का size और site के हिसाब से कौन सा लिथोट्रिप्सी वो ऐसा सीक्वेंस से बताना चाहिए. तुम जैसा ऐसा समझ लेना कि तुम खुद यूरेट्रोस्कोपी कर रहे हो.
Yes, sir. Yes, sir.
Then you will not miss the answer. Okay, वो just can repeat the ureteroscopy. बताओ.
Yes, sir. So under all assertive precautions, the patient is brought to the end of the table. Patient will be placed in lithotomy position with the parts, both the limbs well supported. The imaging will be reviewed again. The CM would be brought inside so as to first take us, after painting, dripping the patient, I will first take a scout film to assess the position of the stone. After that, I would first do a cystoscopy. I will assess the urethra, urethral caliber, any stone in the urethra. I will assess the bladder neck. I will assess the bladder, the ureteric orifices, and the entire the usual cystoscopy for any mass, any other stones. Then I would like to take a ureteric catheter along with a hydrophilic guide wire and insert the guide wire into the side of the stone, and then would come out. Then I would put a 6 or a 7 French infant feeding tube. This will help to empty the bladder during the part of the ureteroscopy. Then ideally I would start, if I have 2 ureteroscopes, I would start with a smaller caliber ureteroscope, and with good lubrication, I would insert and negotiate the urethra, and over the safety guide wire, initially assessing the orifice and going perpendicular over the guide wire, if required under pressure, just to negotiate the ureteric orifice initially, and then go perpendicular to lift up the ureteric orifice, lift up the anterior wall and go inside. Then I would assess the caliber of the ureter. I would assess for a narrow. Yes, sir.
After placing the safety guide wire, again
Yes,
you will go over another guide wire. That is the answer in the exam.
Okay, sir. Okay.
So one safety guide wire is always there. You
And
keep
one
it
axis,
that
sir.
safety guide wire, and you will go over another guide wire. That you have to tell in exam. And while practically people will go directly over the guide wire, without guide wire, वो सब कुछ चलता है.
Okay. So using access wire, then we'll access the ureter, assess the ureteric caliber, assess for any strictures, assess how much is the edema, assess whether the ureteroscopy, the ureter is able to negotiate the ureter under intermittently using fluoroscopic guidance to assess where we have reached. Then having reached the stone, I would first like to assess the surrounding ureteric edema. Then I would like to, with all during the part of the ureteroscopy, I like to maintain the center of vision, the vision in the center itself, and then initially would like to, if possible, if possible, I would like to pass a basket, the wire of the basket alongside the stone and grasp the stone so that it doesn't get retropulsed. Or if not, then I would like to use an energy source initially, which either a laser or a pneumatic lithoclast, fragment the stone. Initially would start with a lower energy.
Okay, Ojas.
Yes, sir.
Stop. Okay. Which basket will you pass?
Sir, I will use a 3 French normal basket, sir. Two
Now
French.
you've taken a nice 3 French basket, big basket. You have
Yes,
grasped the stone. Now you're trying to come out, and your stone, URS, and your basket in place is all stuck.
Yes, sir. So
Correct.
then I will dismantle the basket and
So listen, Ojas.
yes, sir. Yes, sir.
When you put a 3 French basket, no, your
Yes, sir.
flow, just have a look tomorrow, go to the OT,
Yes,
Put a
sir.
3 French basket and see what happens to the flow. It becomes zero.
Yes, sir.
Okay. So
Okay.
eyes cannot see what the mind doesn't know. So you have to understand that if you get into a situation wherein you grasp the stone with the basket and you cannot release it, then you will be in deep sugar. Then you
Correct.
will have to either cut the basket and leave it in place and go by the side of it. This is all of the past. In today's day and time, you must use the right instruments. So the
Okay.
right size of the basket is a 1.7 French basket.
Okay.
And the right kind of basket is a N circle or an N gauge. N
Okay.
circle is available in 1.5 French. N gauge is available in 1.7 French.
1.7.
What is the advantage of using these baskets? Suppose you
Uh,
get stuck in a situation where the stone is stuck in the ureter and you are stuck with the stone, you can pass a laser fiber by the side of it. Still have
Yes,
good
sir.
irrigation and get out of that situation.
Okay.
So the size of the basket is 1.7 French N
One
gauge
point.
and 1.5 French N circle or a tipless basket. Okay.
Okay.
Now,
Yes, yes.
second question, what are the properties of a basket?
Properties.
What did you do? First thing you said you will
First, with the
capture.
basket close, I would like to get
Capture. So the first
capture. Yes.
property is capture. Second
Capture.
property is retain. Retain.
Retain.
Retain. Okay.
And third most important property
Release.
property of a release. Very good.
Yes, sir.
Very good. That is the most important property of the basket.
Okay.
So a basket which follows these three principles is the ideal basket. And
Yes.
N gauge is supposed to be one of the best baskets because its release function is very good. Even if you don't have a trained assistant, an N gauge allows you to release the stone. So
Okay.
when you say that you will use a basket, you must use the right size of the basket.
Okay.
Second, one small correction. You said you will do checkscopy for stones, strictures, tumors, blah, blah, blah.
Yes, sir.
All this in the past, examiners would accept. Even now they will accept because you are saying all that is a good thing to do a check thing. But with today's imaging, now in the past we used to do only IVP. Okay. Sometimes in medical college or in general hospital, still the IVPs are being done. But many of the centers, most of the centers now has moved on to CT scan. So with CT, you can definitely know that you have a tumor, not have a tumor,
Yes, sir.
your lower tract, upper tract, everything imaging is already done. Okay. So unnecessarily too many things you must not add. You just said I will do a checkscopy and start. Because the stone, you have been given a scenario that there is a stone and you are going to URS for that.
Yes, sir.
Okay, continue.
Okay.
And semi-rigid ureteroscope is made only for mid ureter and lower ureter. Theoretically, it is only made for mid ureter and lower ureter. Practically, people were doing lower polar stone with ureteroscopy.
No, absolutely agree with Gite sir. You must not say for maximum upper PUJ stone or kidney stone, you must not say URS. Because in today's day and time, all over the country, RIRS is happening in large numbers.
Exactly.
Yes, sir.
सर ureteroscope semi rigid complete हुआ है तो अपन करेंगे.
Yes. That is what I was telling. Let us have a lecture and then we will continue with whatever is remaining in ureteroscope and RIRS.
Yes.
By that time,
So,
Dr. Maheshwari also will join.
Already Dr. Dinesh Dhodi sir has joined.
Yes. So
So
you please introduce him and let him share his screen.
Yes.
Bharat.
So Dr. Dinesh Dhodi is a professor of pharmacology, Grand Government Medical College and Surgery Group of Hospital. He is a recognized undergraduate and postgraduate teacher. He has having experience in conducting the basic medical education technology, revised basic technology and advanced medical education technology. He is a guide for PG student, PG Pharmac and ICMR STC guide. He is faculty for research methodology workshop, medical education technology at Mumbai Internship Orientation Program. He is involved in various postgraduate PG activities. He is conducting basic medical scientific member and member secretary for institutional ethical committee of a Grand Government Medical College for many years. Had worked as a member in clinical ethical forum, independent of ethical committee of Mumbai Hospital, Mulund, Mumbai, Shroff Eye Hospital, Mumbai. And he is a part of various clinical trials and many publications is under his belt. He is a coordinator for many research methodology workshops, national and international, and conducted workshops and conferences. So here is Dr. Dinesh Dhodi, sir. Please, on behalf of everyone, I welcome you.
Thank you, sir. I hope I am visible and
Yes,
I am
sir.
audible.
Yes,
Yes, you are audible.
Yes. For me,
yes.
this is.
Dr. Dhodi, welcome. I'm Dr. Gaurang Shah.
Thank you, sir. Thank you, sir. Thank you.
Yeah.
Nice to meet you, sir.
And we are very happy to you because this is one of the table nowadays, and it will be very helpful for even the DNB students to decide regarding their research work and their thesis. So please go ahead and share your screen.
Thank you. Is my screen visible to everyone?
Yes.
Yes, sir.
Yes, we can see.
Before we go into the basic research and all this thing, I would like to tell you about we need to create a background for why we are going through this session. This is not new for me. I had taken many sessions on this research methodology and all this thing. I hope this platform which Dr. I thank our sir, Dr. Amul Venkat Gite sir and Dr. Shah inviting me as a guest faculty for this gathering online platform. Just little bit first time I'm taking at this time, and I'll try to justify whatever I'm going to present. Now research for everyone. We from previously we were thinking that okay, in UG also research has been included, PG also it is been included. Nowadays PG plus postgraduate super specialty and everywhere as per the NMC or the university, it has been mandatory to do this basic research methodology plus for postgraduate and for PhD student. One research is mandatory. Now there are a lot of dilemmas and all these things come across how to plan and how to design what problems. We don't think the different angle of the research while designing the research. If we have an 360 view of designing the research, the major mistakes can be reduced when you plan and design a research proper way before starting the study. Once the study is approved and then you go on, when you in the mid pathway, then you think that, okay, I have not think about this parameter and this is important for this. I did not think that this type of patients or this type of subjects will include, could have been included and I have not included. This parameter or biochemical parameter should have been planned beforehand. And now as the design is finalized, we are already the ethics committee and everywhere this has gone. Now changing and then doing again, then it is like you have to start from first. Means you have to begin again. So in between, whenever if your research design is planned properly, you can like planning will reduce all the errors, all the basic things we miss during like hypothesis, all the sample size and everything. With this, we'll be going in this session, what I'm going to take it. Now, what you will be learning from this session is what do you understand by the research, characteristic and objectives of the research, type of research, basic steps to conduct medical research, some basic concept in research methodology, and major important issues in medical research, including the publications. Now, research means a systematic investigation through which I think we collect, we plan the study, we decide the population, we collect the data, we analyze the data and interpret into the particular format which is readable. Now, a lot of the time we collect the data in the form of yes, no, when lot of the time we collect the data in the statistical way, 1, 2, 3, 4, grading and all these things. So these all thing has to be systematically planned, and then when you make a result, when you make an interpretation, it has to be readable to the general population who is going to read your article or who is referring your research in future. So systematic investigation of a problem and gaining a knowledge from it is a research. Now in the same way, scientific research means what we are going to see, what is mean by scientific research. Scientific research involves various steps, what we are going to discuss in that, how to plan a study, what queries, questions comes into mind before even thinking of doing a research, before pointing down the planning of the research, before you even think of sample size, inclusion exclusion criteria, something what we called as hypothesis in your mind, and you come at the end with the result, conclusion, and then complete research. So what you need to do in the scientific research, or if you're not going to wrong, or if you don't, I don't say in the wrong meaning, but we always become little bit in the neglected part in our medical field is like nowadays it has been given so much importance on the publication also, and as a part of the requirement. So what I want to say that any student, any researcher is planning doing a study, if properly formulated study, the mistakes or the bias or any statistical calculation chances going wrong here and there, at the end of the study what we come across, this might be reduced. And we don't depend on the like we give someone in okay, you design a study for me, you design planning for me, okay, you do a statistical calculation for me, okay, you do a presentation of final result and all these things. So all these giving to anyone, if lot of people do nowadays of giving, like in the market there are a lot of players who do all this research, but what is your contribution to that research? If you don't understand what he has done, it will be always difficult you to carry out the research during that period. It is you who is going to finally do the research. It's the person who has designed, who is not at the part. Okay, I can also design the study, not an issue as such, but I am not going to do a urology study and all these things as such. So you are the part of that clinical this thing where the patients are coming, where you need to understand the inclusion exclusion criteria. If you understand these basic things, then you can question it that okay, why this parameter is included, this parameter is not coming into what patient I am going to see, this biochemical parameter is not required, this statistical calculation what I am not means at the end the result will look like this, okay, and what I have planned it will come into this. So all this can be only minimized, or questions should come in our mind when you, and that questions comes in our mind when you understand the design of that study, the protocol of that research, and then what you want. Like basically research is what you want or what you have decided, that has to come out. It may be positive or it may be negative, and the steps and procedure which are planned has to be meticulously planned, that you need to understand. Now, what are the characteristics of scientific research? It, as I told, it clearly demands a statement of a problem. When you are doing or planning, something comes in your mind that you have to write down on paper. You, I can say that in the school, how you write down the problem statement and then you find out the answer. In the same way, you have to write down the questions, what is coming in your mind. Okay, and then you have to think that what you're thinking is logical or it is visible in that main means your question is this correlation, is there any correlation between this procedure and what is outcome, is there is any effect of this drug on this outcome and all these things. So the it always asks you the clear, if see basic When you are not clear with what you are going to do the research, it will be always difficult during the study also and after the study also. So the clear statement of question, what you say as a hypothesis, has to be very clear in your mind. During establish, it may be sometime we think on establishment of the some facts. Okay, this procedure, this outcome, this drug, this outcome, this drug, this adverse drug reactions. Okay, so what is the correlation between this exposure, now bladder cancer with the smoking and all these things? You need to have that relationship between the cause and the effect. You cannot just think that X and you can correlate A with the X and A with the Z, where there is no correlation between them. There should be correlation between what you are thinking. Okay, with the literature and all this thing, you can think that what is the correlation between two effect and the outcome. That is need to understand. Requires clear objective and the plan. As I am again and again telling, if you are objectives are not very clear, your plan of the study is not clear, again it will be a problem. It should be built on the existing data. You have to search the literature. What are the current literatures available? What are the positive, negative? Not only focus, please don't focus only on the positive finding. See, now we obviously that lot of researchers think that hiding negative is like, but please don't hide the negative findings. You have to highlight the negative findings also. Either it may help to individual who is going to read your article in future or study in the future, will help to reduce the further same mistakes what you might have ignored and all this thing. Okay, so all these need to be understand very clear. Okay, new data is to be systematically collected and analyzed. So these are the characteristics of a good scientific research. Objectives. And what are the basic and broad term objectives of the scientific research? It adds scientific knowledge to already existing knowledge. It improves the medical and the health practices. Study new phenomena of established fact as such. You may, there are a lot of facts which are, lot of literatures are there. These cause, these effect, outcome and all these things are there. Still there are dilemmas on some phenomena, that this can happen due to this procedure, this can happen due to this drug, this may happening to some these habits and all these things. So these can be again established by a good research. Help in planning. Studies are not only done for the establishing fact of or the drugs and the effect and efficacy or the procedure. Studies can be planned for the diagnostic procedure also. Studies can be planned to have an implication, see the effective implication of the health program. Now, a lot of health programs and health plannings are there. Without assessing these health programs, now COVID and all these things, these programs are evaluated. Lot of studies are going on the COVID vaccines, COVID health programs and all this. So studies are not only for the individual subjects and all this thing. In broader term, studies are done for the health programs, and it helps in the effective planning in the future as well. Improve diagnostic technique. In your urology, some techniques and is there you want to establish, you have to do a research, you have to go into deep this thing, you have to publish the data, get established the technique, and then only you can say that this diagnostic procedure is okay and it will be accepted all over. Without registering or doing a research or notifying the research, it will be difficult for individual or the other people to accept what you are telling us. Effective patient care management. This is a part of each and every research where we think finally that something should be effective or reduce some harm to the patient, or the patient care will be benefited in long term. Now, in short, what we are going to see is the steps of conducting a scientific research. There will be a problem stage, there will be a planning stage, and execution stage. Now, if you see in the problem stage, what we are going to see in the problem steps? Formulate the research question. Now, always your dissertation, your research tells you to write down the research question or your hypothesis. Now, research questions may be in the broad, this thing may, you have to think that what exactly you are going to, there should be some question in your mind. Write down that. That same thing will be considered as a, in scientific proper way, you have to write that question and that becomes your research question. On that basis, you can formulate your hypothesis. Okay, if you can say A drug is better than the B drug, or B drug is better than the A drug. So you have to, what we hear normally as a alternative hypothesis and null hypothesis. Okay, we always go with the null hypothesis, and if it is disproved, then the null alternative hypothesis is proved. So that will be further looking into the hypothesis and alternative hypothesis. Now, step 2 is, once the questions is formulated in your mind, once you have written the basic questions, what you need to do is do a detailed research on the literature. What are available research? What are the publication which is there? What are the parameters which has been taken by the other research? And then you can get an idea that this research question, how you are going to further investigate clearly and in the specific term. Now, these literature will tell you that what type population you can select, what are the parameters what others have planned, what are the scientific terminology which has been used, and these give and reference to your research. Okay, so literature survey is very much important before, if you, before exactly you are starting the study. Okay, don't do research. Literature supports can be taken during the study, but for designing the study, you always go to the literature and then give a support to your question to further design. Identify and define your key concept or the variables. Now, these like variables means what you are going to exactly look. Are you going to see the urine output? Are you going to see a urine investigation? Are you going to see a microbial culture? Are you going to see some basic procedure where you are going to divide that procedure into every steps of like cleaning of your before the procedure, what you are going to do. Now, what are the adverse of doing that procedure? All these variables are pre-designed. Exactly. You cannot say that once you start a study, this parameter I'll record. I have not planned this variable, but I have found out this thing, but that will be not calculated as valid variables or varied findings. Okay, so identify and define your concept or the variables and relate them each other. Okay, formally now in that variables also you need to understand that age, sex, which type of complaints, symptoms we are going to include. So these are the, you need to understand. Okay, then steps 4 is formulate your study objectives, hypothesis, research question, application. Now, now formulating the research question, this can reduce. Okay, this can, the researcher, like these questions can be depending on the researcher interest, experience, observation, researchers ongoing work, matter arising from the works of others. So all these can come together and then you can formulate a proper question, and these can be, there is a one finer criteria. Okay, to this final criteria for good research question, it should be feasible. Now, feasible in that means of that simple meaning, उतने number of patient subjects को रहना चाहिए, उतना adequate technical expertise होना चाहिए. ओके, ये feasibility है. अगर ये feasibility हम वो procedure नहीं कर पाएंगे, then it will be difficult. You have planned something which you are not expert in that technique, and then you may be failing into that thing. You have planned some patients who are, you are not looking in your routine practice, you are not seeing that patient. And if you have planned from some literature, I say type K patient, this type of complaints are there, and you are going to include. So think logically that what type of patient, what type of subject you are looking day-to-day practice, then you have to, then in considering that into mind, you have to plan this. Affordable in the time and money. Okay, logistic, there are a lot of procedure will be costing. How much time you can dedicate? ऐसा कोई study नहीं plan कर सकते, 2-2 5-5 साल तक चलते रहे, and you are there are studies which can be planned, there are studies which are going for this thing, but there should be start and there should be some end point of some study as such. So you have to be logistic and feasible, manageable into the scope of your, means if you are a student, if you are, what is that scope, what is your scope that you are thinking too much, which is not out of reach to calculate. Okay, you have something that which you can have, you don't have that much time, you don't have that much money to do that risk. So that technology and all this thing, so feasibility is the most criteria in that finance. Interest, yes, until okay, I think that if you are planning a study, you are doing out, you have interest in doing that research. Now interest, now different nowadays compulsion of doing the research, doing the publication have make that interest little bit difficult to judge that that person who is doing the research is exactly interested or just doing the research for the publication and getting the name and fame. Okay, so this is the wrong idea. One thing is always remember, interest should be there in the doing the research. And what I accept myself, once we are in the medical field, when you are admitted into the medical field, you are always a learner and researcher. You cannot say that I will not do research. You are always doing a research, even if you are treating the patient, even if you are directly or indirectly, you are trying to come to the conclusion, trying to give a best of your knowledge to that patient's outcome and all these things. So every time you might be seeing new findings. So interest is must for any study. It should be a novel. Novel means new thing. जो है already तुम कितने बार prove करोगे? You are wasting money, you are wasting time and all this thing. So don't put your foot where already simple example, hypertension and okay, smoking and cancer and all this thing already proved, diabetes, obesity and diabetes and all this thing already proved. So why these lot of thousands of research, and you cannot refute that there is a correlation. So always think of new, or even if it is not new, it has some doubt when you start the study that okay, बहुत लोगों ने किया, but this part has not been touched. Then ethically it should be amenable and study has to be approved. So no study can start without the approval of WHO. So all ethics part has to be there in the, otherwise you, what harms to the when include the subject, include the patient, designing the study, logistic, if you're not okay, you have to think that you will be the part of the study and then design the study. It will be rare chances that ethical committee will question on that. So you put yourself as a part of the study, you will be ready to take a part in the study, then no issue as such. Relevant scientifically, the knowledge should be scientific, includes clinical and health policy, future research. Literature search, already I have told that literature search, it has to be from the good textbook, reference textbook, national, international journal, article. It may be a case report also. You can start with the case report also. So explain the problem for the investigation, clearance, visit. So literature search has to be done. Identify and define your key variables and relate them to each other. Now, what are the variables? Characteristic which is measured. Now, in simple meaning, height, weight, age, or body BMI, all these are the variables. Okay. Also, if you are doing an investigation, parameters like CBC or urine culture, urine examination, all these are the variables. Okay, so these variables has to be identified, important to the research. Just okay, basic variables are always there with the age, height, no, socio-economic and everything are there, but specific to your study, you have to be very clever while selecting the variables. Okay, so that the variables only will tell you that what you have designed, what you have calculated, the results which are coming out of the variables are countable, or it may be quantitative or qualitative. So understand, okay, your urine volume and all this thing will be a quantitative type of thing. Okay, so all this has to be understand what variables you are. It are only the parameter. Variable is nothing but the parameter what you are going to take or record during your study. So that are very important. Okay, formulate your objective, hypothesis and result. Hypothesis, tentative or prediction. We don't say, no one says that what you have planned is going to get proved only. Take out the myth of that thing. The hypothesis which you are question, or the question which has been you have started, is always going to be proved or whatever. It may be negative also, it may be not proved also. Okay, so based on the previous findings and all these things should indicate the direction. Okay, simple example, obesity increase the risk of hypertension. Okay, so here my null hypothesis, obesity increase the risk of hypertension. Alternative hypothesis, obesity does not increase the risk of hypertension. So this is a simple example of null hypothesis and alternate hypothesis. So when you come out with your result and all this thing, either you that findings will prove your obesity increase the risk hypertension, or obesity does not increase the risk of the hypertension. So either your null hypothesis or alternative hypothesis will be proved. Okay, so anything will get proved. So at the end, excess fluoride in the water causes dental fluorosis, or excess fluoride in the water does not causes the dental fluorosis. So alternative and null hypothesis. Keep it very simple. Now research questions. Now here I have taken a simple drug A is better than the drug B. Now research is, my question is like, is drug actually better than the drug B? Okay, this is a question, but how you are going to prove it? Okay, there should be some parameters or variables which now it should be the drug A is better to get administered. The drug A can be given orally, then compared to the drug B, which is has to be given injectably. Drug A has a less side effect. Drug has a better cure rate. Drug A is a little bit cheaper than the drug B. So all this has to be analyzed. Your question is there, is drug A better than the drug B? How? The parameters are these all, and these all have to be calculated or yeah, recorded. Okay, and then these recorded statement as a parameter will be evaluated statistically, and then it will be proved that is actually drug A better than the drug B. So similar way in your research you can plan out, and then to prove that you have to take various variables. Now this thing we have already, we hear this thing, aims and objectives always, not only in a general term also, what is your aim in your life and all this thing, but we are not clear with the objectives to achieve that aims. Remember, okay, aims we just say that okay मुझे ये करना है लाइफ में, but objectives are not clear. ये कैसे achieve करना है? Okay, that are objectives. Objectives are more specific. You can just remember, aim is little bit broad term as such, and objectives are more specific. Objectives are more calculative. You can calculate that objective in your parameters during the research. Aims focus on long term, focus on the list of practical objectives are more practical and task oriented, and it should be brief and concise. So remember, aim is little bit broader term, objectives are specific, calculated, Okay, measurable, you can say smart criteria, specific, measurable, achievable, okay, and again reproducible and tested as such. So again, these objectives, if someone other do the research with your objectives, he will get same findings and all this thing. So objectives should be very clear. Now we have seen that problem statement. We have understood how the hypothesis and all this thing has to be planned and all this thing. Now the second part is a planning as such. Now this planning is, now we understand that protocol or design of the study. Each, and we at Grant Medical College, we had tried a standard operating procedure for designing a research for the submission of this thing. So that in that we have given what has to be included, from the introduction to the review of literature, then the research question, hypothesis, then the references and how the references should be there. Okay. So in basic planning, you need to, as I'm telling in start only, if you have not planned it properly, there is a sure chances that you might missing something, or you might over this thing, you can say overconfidently, if you go on like okay चल जाएगा, ये नहीं include करेंगे तो भी चलेगा, but when exactly when you start your collection of the data, and when you think, then you think that अरे ये पैरामीटर लेते तो अच्छा रहता था, ये बहुत से इसमें आ रहा है. Okay, so good planning is very much important, and it has to be validated. Now validated in the term of internal validity and external. Internal validity can be done by give what you have designed, give someone to read it, tell him to come out with some questions, and it has to be again and again revised, and then finally it has been properly designed. Then only you go for the studies. External validity means that once you have designed properly, this has to be, you have to think that these findings or this is similar to what naturally what I'm seeing in the population. And when my findings come, I can say sure this finding can be generalized to the entire population. If you're not sure that what you have done and your research has come out with something, and you cannot surely say that this finding is majorly found in the most of the population with affected such type of disease. Okay, other means if you are not sure, means you are not properly validated your design. Okay, so all this validity has to be very much important. Now in this conducting, you have to understand that what you are actually designing, what type of study you are planning. Either you are planning observational study, or you are planning an experimental, or you are experimental in the term of intervention study. Okay, now there is a lot of doubt in the researcher that what type of study I called as observational study. Always we ask the question to the presenter in the ethics committee or this thing, okay, after study observationally or intervention. Now you understand that ethics committee or other any reviewer, if it is observer only observational based study, there are very less chance of ethical issues and all this, only about a confidentiality data and all these things. So if there is no intervention, it is like okay, we are sure, okay, observation study है, for a student है, okay है, चल जाएगा, सब parameters okay है. Now remember observational study where you are absolutely doing no interventions, not even introducing of any diet, not also means if it is a routine part of that patient treatment, no issue. If does not come in that standard guidelines or the routine treatment part, and you are trying to intervene by a diet, trying to intervene by exercise. I'm not talking about the diagnostic procedure, not talking about drugs and all this thing. But even if we think that अरे क्या उसमें observation study है, मैं तो थोड़ा ये इसको diet ही change करवा रहा हूँ, मैं थोड़ा इसका exercise pattern change कर रहा हूँ. No, then means you are intervening something. So remember, observational study is purely whatever is going on, you are just doing observation and writing the findings. You are not allowed to do any intervention, any other than required treatment part and all this thing. Remember, so if your study fits into that, then it is observation. Now, opposite to that, if you are doing any intervention, minimum, minor also, remember minor also, then also it will be considered as a intervention study. So remember, so any intervention, it is intervention study. Either it may be investigation, procedure, it may be exercise, it may be dietary or anything, okay, which is not a routine part of the individual whom you are involving in the research. Now there are a lot of observational study and all this thing, intervention studies, cohort. Cohort is a now population. This term we have learned in a PSM, preventive social medicine. This term it always that okay, we are always get confused about cohort क्या है, case क्या है. Cohort is a population. एक गांव में उनको exposure है कुछ तो, और the common exposure है कुछ gas, you can say relate to the Bhopal gas tragedy. All the population around that Bhopal gas tragedy are exposed with that gas, and they become a cohort. Okay, they have some common exposure in them. Okay, case control study. The S, it says that case and control, you are following two parts. One is the case who has some condition, and comparative, which is people who don't have that study. So case control study. Cross section, when you say a cross sectional study, a study in which the data is collected only by observing many subjects at the same time. Now remember, cross sectional study means you are only observing once, you are not following up. If there is a single follow-up also there, you cannot claim that it is a cross sectional study. If any follow-up is there, even if the questionnaire based study follow-up is there, then also it is not. If it is one time questionnaire and many individual can be taken in the same point of time, is a cross section. Intervention, now these randomized, we hear that RCT trials are accepted well by the publisher as well. Yes, they will accept this thing because the design of RCT is that meticulous, and it is not easy to manipulate anything, and lot of, you can say, bias is reduced. Okay, individual bias. Now randomization reduce, if I am an investigator, it reduce my chances of being a bias for selecting. Okay, ये group में ये patient का symptoms ऐसा है तो इसको ये drug अच्छा रहेगा, ये symptoms वाला ऐसा है तो इसको ये drug. So that is my bias of thinking ऐसे. Randomization में क्या होगा, there is already predefined computerized program या cheat block, whatever you can plan out already, या फिर फर्स्ट कम फर्स्ट, यानी पहले जो आएगा उसको ए देंगे, दूसरे आएगा उसको बी ड्रग देंगे. सो आई डोंट हैव दैट चॉइस. Randomized controlled trial. Now there is a blinding, single blind, double blind, and triple blind. Blinding means, single blind is mean that where the population or the subject whom you are including in the study does not know what is the procedure. You will be explaining that, okay, if I am giving the two drugs, I am not telling that him तुमको A ड्रग मिलेगा या B ड्रग मिलेगा. आपको ड्रग मिलेगा, लेकिन कौन सा मिलेगा ये मैं आपको नहीं बता सकता हूँ, क्योंकि ये स्टडी का पार्ट है. So the patient or the subject who is involved in the study does not know about what type of drug or what type of technique which has been used in him as such. So that is single blind. Double blind, when the patient also or the subject who is enrolled in the study and the investigator also don't know. This is like, it is blinding. Okay, where किसको A ड्रग मिलेगा, किसको B ड्रग मिलेगा, ये मेरे को भी नहीं पता as an investigator. So that is double blind. And triple blind means when the study data is collected and when it is compiled, when you give to the analyzer, the third partner of blinding is a statistician or the evaluator of the study, he also don't know that which is A ग्रुप में क्या ड्रग दिया गया है, बी ग्रुप में क्या ड्रग दिया है, so he will evaluate in it. So triple blind little bit difficult होता है evaluation ऑल, but single blind, double blind design, if it is proper, then it is the best type of design in current scenario, and this will be best accepted design as such. Now then the data collection start. Now remember case record form. Now always we see what problems comes with the student. अरे ये मेरा खाली age, sex, ये वो. They think that this is only the case record form data collection. No, data collection form or the case record form is a complete thing what you are going to recording. You may record clinical history, you may record surgical history, social, whatever it may be, age, sex, income, and everything, whatever you want to. But remember, ethics committee will ask you why you are recording this. If it is questionable, you have to, okay, this parameter is important for my study, I am recording. And if it is justifiable, ethics committee will say it is okay. Now there comes the question of religions and all this thing. You always ask religion, Hindu, Muslim, Sikh, and all this thing. If it gives some outcome, then only record such type of data. So that social impact and all these things. So ethics committee not only see these parameters which are objectives like blood and investigation, social parameters are also seen as why you are recording this thing. There should be no controversies in asking the question. Even if a survey is there, why you are asking some. Now you are in the urology. There are a lot of people who design a study and sexual dysfunction, and all these things. So these are the where you need to ask some intimate questions and all these things. So need to remember when you design the question, it has to be accepted by the individuals who are going to be part of the study and also by the ethics committee. So designing the questions, remember, and each and everything what you are going to record has to be, you have to give in tabulated formula. Okay, CBC is recorded how many times? Then CBC in that, okay, what you are going to see CBC? Are you going to see hemoglobin? Are you seeing to neutrophils, lymphocytes, whatever? You give in detail. Now how, not only what you are going to record in CBC or urine examination, you have to give the units also. It is ml, it is in percentage, everything. So remember, case record form is to be very detailed, where we understand or the reviewer understand what you are recording, how many times you are recording, and all this thing is justify as per your study. Okay, lot of the students make a mistakes here. They don't design case record form properly, and we have to again give them repeat and repeat, and they have to refine and all this thing. So design your case record form properly. Sample size, I'm not expert in the sample size calculation, but remember that sample size is the important. When you are going to generalize the findings, it depends upon the sample size. If you are taking too small sample size, it will not able to means you will be not able to relate that findings to the general population. If it is too large, you are going to waste your time, resources, and money. So appropriate sample size has to be mass and it has to be justified. Okay, so it may lead to just rejection of, if you have taken a too small population, the findings that the effectivity of the drug may be not accepted. So that you need to remember. So calculation. So there is a calculation method, basic formula. This is more statistical part where you need to understand typical 5% level of significance and 80% power of the study. If you go in detail of this is little this discussion is totally altogether statistical. I'm not going detail, but do remember the sample size calculation is, because always when you ask the students, they are literally they are thinking, यार sample size में क्या है, 100 ले लो, 50 ले लो, क्या फर्क देता है? But if you are, your sample size is not appropriate, you will be not able to generalize your finding to the general population. इतना कॉमन प्रॉब्लम है, उसके लिए यू हैव टेकन ओनली 30-40 सैंपल। ओके, हाइपरटेंशन में कुछ कोरिलेट करना है तो 30 पेशेंट को लेकर थोड़ी चलेगा। ओके, इंसिडेंस ऑफ हाइपरटेंशन इज हाउ मच कॉमन, इंसिडेंस ऑफ डायबिटीज इज टू कॉमन। उसके लिए 100 पेशेंट का डेटा तो तुम बोलोगे कि पूरा करोड़ों पेशेंट को एप्लीकेबल होगा, नहीं। यू हैव टू कैलकुलेट दैट appropriate sample size, then you can say कि वो लॉजिकली वो अप्लाई हो सकता है जो फाइंडिंग्स है। So finally, after coming all this discussion, you have to write down in the term on pen and paper or design proper. That is a blueprinting of your proposal. What is proper protocol? It is a blueprinting of what the work you are going to do. Describe the goals of the state, the hypothesis, describe material methods, everything, case record form, a consent form, and then this all goes to the ethics committee and ethics committee. Okay. Now in execution part, you need to understand, we always ask as a ethics committee that इसमें कौन लोग इन्वॉल्व, ये you are what is your role exactly you are doing? Are you doing the recording? Are you doing intervention? Whatever plan, your role, you need to understand what exactly a investigator is doing. Now student says मेरा guide करेगा, मेरा ये करेगा, वो करेगा. No, what we are asking is तुम क्या करने वाले study में? Guide is a supportive part. Guide is not an active part in that thing. As a prime investigator, you are the main worker. No people, no student give in detail that nurse ये करने वाली, वो करने वाले है. अरे, it is your study. We don't depend on the nurse. ये parameter record करने वाली, मेरा other junior ये करने वाला है. No, it is you, whole and soul of that study, going to record. And if you, so before execution, you need to design your, you need to plan your team also. Okay, so either it may be your colleague, either it may be that nurse, either be your senior. Everyone has to be tell about, you have to take a training of these people and then tell them what you are going to exactly. Otherwise, what you want, they don't understand. And if they are not knowing about the research, they can't help you out. Simple thing. तुमको क्या चाहिए उनको पता ही नहीं है, then you are asking कि तुम ये लिखो, वो लिखो, then all recording will be going wrong. So remember, all the person in the study has to be properly trained. Okay, अगर कुछ हो गया वो study में, then you are only the responsible, वो उसका नहीं हो. Okay, you have planned the study, you will held responsible for anything going wrong in that study. So remember, okay, or make them responsible, involve them into the study, and then start the study. So then once you collected data, generalize, वो statistical calculation हो गया, आपने layout बना लिया, ROL लिखा, आपका literature लिखा, result बनाया, conclusion and all this thing, and then your finally all this research is on paper, and then you go for the publication. Now there are few, I'll take a 5 to 10 minutes here final. Now there are few ethical issues in the research. Now what are the research? Already I told you about the bias of selecting the individual. There is a proof of efficacy and safety. We need to prove that what parameters you have taken for efficacy, what parameter you have taken for safety. Informed consent. Now consent is one of the major issue wherein we all as a researcher need to understand, even if you are doing a study or even if you are doing a procedure, informed consent has to be properly documented. The one document which can save you in the court of law is informed consent properly recorded. Okay, and that has to be there in the, we write very short, there is a standard format in the lot of, you can add up more thing into the consent form as per the procedure, so that it can, whenever if by chance there is a negligence or something case and all this thing filed on you, informed consent or something will be helpful to save you. Now ethics issue in the research, do a double blind test, give a new drug to the rich patient and placebo to the poor. So all things were the issues in the previous study, age long, and there are a lot of issues which has come out, that Currently also there are unethical trials, research goes on. Even if you go into the Google and search the ethical issues in the clinical trials, still there are unethical. We also knowingly, unknowingly take one mistake. What we did, taken granted all the subject population. We think that ये पेशेंट को तो जरूरत है, उसको क्या है, चल जाएगा, मैं थोड़ा उसका टाइम और उसको थोड़ा एक्सपेरिमेंट कर लेता हूँ. So that ethics, the thin line between of doing a procedure and not telling him is there. So then this already I had covered. Justification of the study is must. Okay, why you are doing it? Simply आपके enthusiasm के लिए study नहीं कर सकते. Remember, it has to give some scientific reason, then only. Otherwise कोई ethics committee will not let you do the study. कुछ तो नया या कुछ तो justify करना पड़ेगा. Design should be properly in design. Main thing you remember, inclusion exclusion criteria. The patient which are exactly as per your study has to be included. कोई भी patient को include, either you are going to waste your time and all this thing, you are going to harm the patient. So select, but you cannot include just for your enthusiasm to children's age old and all this thing. You can include that patient if the study is for them. Otherwise just for your enthusiasm, ये type के patient मेरे को मिल रहे तो यही patient होगा. No. So during the study design, your study type has to be very clear, intervention, observation, whatever. It has to be justified. Sample size, as I discussed, and that selection of the subject is very much. Remember, if your selection goes wrong, whole studies goes wrong. Remember this point. ICF and patient. We never see the PIs or in our routine studies and all that. We always see a short form of consent where there is nothing mentioned about the study. Do have an habit to write down everything in the short. That patient ko, but you have to tell them that what is the study, why you are going to involve that person or subject in the study, कितना blood लेने वाले हो, क्या क्या procedure करने वाले, कितना follow up है, everything. Okay, so that information has to be there in the consent form. So then if the patient वो sign करे क्या करे, that is different thing, but tell him. So there take a signature, proper recording and all this thing. Consent form is important. I already told about case record form. Placebo, in current scenario, only the possible of using the placebo is where there is no treatment available. No treatment available, there you can use a placebo, or in the minimum discomfort that okay इसको ये दवाई नहीं दिया तो भी चल जाएगा, then only it has to be justified. You cannot say that severe grade of pain है और उसको ये दवाई प्लासिबो देके देखते और दूसरे पेशेंट को द actual drug देंगे. No, mild pain which is bearable can be accepted for placebo. Remember. So similar way, wherever there is no treatment or acceptable bearable discomfort is there we need to. Conflict of interest, remember. Study design, I'm not going this, all thing has to be very minimum discomfort, appropriate comparator, concomitant medication. Remember in the design, concomitant medication, no medication has to be stopped for your, just for your benefit of the research. It has to be justifiable what you are stopping and what you are starting. Okay, always say ये पुराना drug stop करके मैं नया drug. You have to justify that thing. You have to allow the subject to take the other medication if he is in the discomfort. You cannot just say कि मैं stop कर दूंगा, मेरा study में ये नहीं है तो ये नहीं चलाऊंगा. No, you have to need standard recording of the adverse. Now remember, adverse effect, it is our responsibility or the researcher responsibility that you have to record the adverse effect, and the first prime important is to treat the adverse effect. Any negligence in delayed treating in adverse effect, it will be dealt very seriously, and that will be having a bad impact on your research, not only on the research, but you will be found not negligent. So adverse effect, any compensation, traveling, death, or whatever it has to be declared. Selection criteria, age, gender, wherever if it is required, then only include childbearing and all this thing. Clinical need to remember stable, unstable emotional patient, need to remember psychiatric patient, and all these things has to be avoided. Otherwise, it may have other problems, history of the disease, wash, okay, occupation, and all these things. There are some drugs which affect the remember occupation. Why? If the person is driver, if the person is involving some fine work and all this thing, and if there is a sedative drug is given, and by that sedative drug some happen, some damage happen or some mishap happen, then you will be responsible. Remember, so occupation has to be understand, advised improperly. Okay, so consent is the important. As I told, all detail has to be written in the consent. Why the research is being done, what research you want to accomplish, what will be done and how long, risk and benefit, other treatment available, can withdraw from any from trial any time, compensation for unexpected injuries and all this. Placebo, I have already told you, if there is a proven treatment available, you cannot use placebo. Remember, conflict of interest, situation in the financial and other personal consideration has to be considered. Okay, if there is some if you are doing a research on some molecule and you have some conflict in that financial, or you are doing a work, you are marketing for that drug and all this thing, you need to remember, you have to declare that you are part of that company and you are doing that research. Confidentiality in the term of, like, you will keep the data and all this thing confidential until which is required by the regulatory authorities, then only you will be declaring that data and all this thing. So confidentiality is maintained, is a part of a duty of the investigator. Remember confidentiality and remember privacy. Whenever you are examining the patient, there should be no awkward moment for the patient where you have to keep privacy of that individual. कोई भी patient आ गया और उसको कुछ भी कैसे भी examination, no privacy, nothing, you are touching here and there. This thing has to be understand. If you are a part of the study, then if you feel how you feel if the someone is doing like this with you. So remember, privacy is important for each and every, even if it is poor or whatever patient and all this thing. Remember the privacy. Last part is about the publication. Now, when you go on doing, when you have completed the study, you have always, I say that you publish the research, either is negative or positive finding, whatever, do publish it. Authorship can be given only, remember, authorship can be only given to the individual who has contributed in some way or other way to that design, research, evaluating, evaluating the data, finally preparing the result, preparing the publication, then only you can give the authorship. Just he is your friend and he not only, he don't know about your research and you are giving authorship. So don't do like this. That is not accepted, and that ethically is not right. So authorship only to be given who has contributed. Plagiarism, nowadays lot of software and all these things are there for plagiarism. So do not, what do you mean by plagiarism? Copying the idea of some other author and all this thing and not giving the reference in your literature. Remember, give reference even if you copied a line from that. Now what we do is थोड़ा उसमें से copy किया, इधर से copy किया, and we present as our idea. So please don't do plagiarism. Salami slicing. Salami slicing में हमने एक ही स्टडी डिजाइन किया है, एक ही स्टडी किया है, देन यू आर पब्लिशिंग लिटिल पार्ट, पहला पार्ट मैं इस पब्लिकेशन के लिए करूंगा, दूसरा पार्ट दूसरे पब्लिकेशन. नो, यू कैन नॉट कट डाउन द पब्लिकेशन इन 3-4, क्योंकि पब्लिकेशन यू माइट बी थिंकिंग कि मेरे पब्लिकेशन बढ़ जाएगी. Please don't do salami slicing of publication. Do your publication in one, okay, and give to the one publisher. Double publication. Double publication means you have already published your data and you want to publish into, अरे वो तो क्या सादा जर्नल है उसमें पब्लिश हो गया, मुझे अभी नेशनल इंटरनेशनल जर्नल में पब्लिश करना है. No, any journal you have published, either you declare that thing that I have published in this stuff which is not index or whatever, and write down in detail that yeah, I want to publish in some index journal, so I am giving this. Okay, so let it be for that editor, author, or publisher to decide on if they want to publish your data or not. So without listening, don't publish. Not publication of negative data. Always remember that you are making a mistake. The same mistake will be repeated by other publisher also. So remember, all these are about the publication ethical issues. Now, summarizing my presentation, I have tried to just tell you in one lecture it is very difficult, and on that also on the online it is difficult to, where we take this for 3 days designing and all this thing. Designing a protocol also it is a full day, and all this thing. Design and study it will take lot of time. Only inclusion exclusion criteria will take one session. Each and every part of the study hypothesis will take one session. So what I want, that whatever justifiable today, what I am able to tell you, okay, so that little bit if you can implicate, always think, I am in the, as a part of the ethics committee, I always see that people don't, okay, go wrong anyway in that research, even they are unknowingly. I always point out that this is wrong, this may lead to these issues and all this thing. Either maybe it may be some social issues, it may be other, this parameter is not accepted, other. So always remember, do a ethical research, do a ethical publication, and learn how to design the study for your own research. Don't depend on other to design the study, then depend on other to prepare the result, and then depend on other to, okay, to publish kar de, and I'll give you a 10,000, 20,000, whatever. That is not an ethical way to do a research and the publication. Thank you from my side. I'm ready to take the question. Any query, any questions? Okay, you can let me know.
Thank you, Professor Dhodi, sir. We are very thankful on behalf of Clinics of PG Update. You have made a very difficult topic taught by a simplified way, and hope the students, as far as the exam is concerned, they will get benefited, definitely get benefited with after your class, because that is one since last 2 years there is one table viva related to the research. So you have very systematically covered each and every sector of the research in today's class. So from my side and from Clinics of PG Update, again I am very thankful to you, sir. Thank you, sir.
Thank you.
Thank you. Thank you very much. Thank you.
Thank you. Thank you. Any questions? I'm okay if anyone, any student have the questions. If no question, I'll take a leave if no questions.
Okay. Fine.
Thank you, sir.
Thank you, sir. Thank
you, sir.
Thank you.
So, Gita sir, let us start now. Okay, from where we have left.
Yes,
Okay, Paras, you can.
Sir, I just wanted to add one or two questions to Ojas from where we left.
Yes, sir.
So, Ojas, you were saying that we'll use a basket to prevent the stone migration. So, are there any other devices? Are there any other devices which can be used during ureteroscopy to prevent stone migration?
So we can use a grasper, but that is not prevent migration.
Stone cone,
Correct.
Stone cone, yes,
There
sir.
is
Stone cone.
something like a stone cone.
a
So
corridon.
what does the stone, how does it work? It is like a zebra guide wire. It has a
Yes, sir.
stillet
Yes, sir.
inside. So once you do ureteroscopy, like you said, you enter over a wire, you can enter over this wire, use it like a wire. Once you see the stone, bypass the stone. And then when you put the stillet inside, it forms a coil. So that is called a stone cone. Then
Yes, sir.
using the cone, keeping the cone in place, you can laser the stone and all the debris will remain there. Then is there any basket like a cone?
Accordion.
Sorry,
Accordion, sir.
accordion. Yeah. Okay.
Accordion.
Yeah. So there is a basket which forms a mesh. Okay. So that mesh kind of a thing, it prevents the stone fragments from going up. Then some people in the past had done some research. They had made some kind of gels and also used xylocaine jelly, but the results were not that great. Still, migration still happened. Okay, continue.
Yeah. So just now identify. Ureterinoscope already you said. Don't talk about that.
Ureteric catheter. These are ureteric catheters. Ureteric catheter has is the length of the ureteric catheter is around 70 centimeters. Marking is 50 centimeters. The rest 20 centimeters not marked.
See properly what it is.
Are these catheters or dilators?
Dilators.
Dilators,
These are ureteric dilators, sir. Serial ureteric dilators.
Ureteric dilator. Yes, sir. Yes, sir.
Yeah.
Yeah. Ureteric dilators. Okay. Yes, sir. These are serial ureteric dilators. This would be used if we have if initially if we have an upper ureteric stone in which we want to dilate the ureter so as to accommodate a flexible scope, we will be using a ureteric dilator so as to dilate the ureter. The other option is using a balloon dilator for dilating this ureter.
Okay. So what sizes you get it?
So 6 French to
6 to 14.
18. 14.
So you said, Ojas, you said dilatation to accommodate the flexible ureter scope.
Or a larger scope, sir.
Okay. So what is the size of the flexible ureter scope?
7.5 French. Usually it will be the size of the flexible ureter scope, sir.
Very good. And what is the size of the semi-rigid scope?
A semi-rigid scope can vary from Wolf 4.5 and
Correct. But usually what do we use?
6
usually we
by
use
7.5.
7 or 8, 9.
Correct. So do you know what is calibration?
Calibration is dilatation of a tubular lumen. Assessment of the tubular lumen
Very
by.
good. So most of the people now doing flexible ureteroscopies, they are not doing blind dilatation. So what is the type of dilatation they are doing?
Balloon dilatation.
No, endoscopic dilatation.
Okay.
Endoscopic dilatation means you're going to have a look at the ureter and you're going to use your ureteroscope to assess the ureter. Okay. So the teaching goes that if a 6 by 7.5 French ureteroscope goes in, usually a 9.5 to 11.5 access sheath will walk in. Okay. And if
Yes,
a 9.8 French ureteroscope goes in, then your 12 to 14 French access sheath will walk in. Okay. Are there any factors to predict whether there will be a safe insertion of access sheath? Are there any factors?
So first that if on a preoperative imaging we find there is hydroureter.
So that is a lower ureteric stone. You're right. If there is a lower ureteric stone with a kidney stone, you know that the ureter is dilated. But I'm saying generally in a patient who does not have a lower ureteric stone, are there any factors to determine that this patient maybe the access sheath insertion would be easier compared to the other patients?
Prior insertion of a DA stent.
Correct. So prior history of URS or DJ stenting. Second.
History of prior passage of stones.
Okay. So prior intervention, either URS or DJ stenting, old age, okay, and lower ureteric stone, like you said. Okay. So calibration is assessing the ureter using a ureteroscope and seeing what kind of access sheath can go in. Yes, now sir. You said 7.5 French is the normal size of the ureteroscope, the flexible ureteroscope.
Yes, sir.
Are there any newer generation scopes? Okay, we'll come to it during flexible. So you finish now with the dilators.
Yes, sir. So, yeah, so
So these
this
are
will be,
serial telescopic dilators. So you
yes,
must
sir.
know different types of dilatation. One is dilatation using this serial dilators. So one by one you assess under CM guidance.
Yes, sir.
Second is balloon
Balloon
dilatation. So
and
there is a
endoscopic. Yes.
so there is a marker there, and you must see that the waste disappears when you put a balloon, and you have to use contrast in the balloon.
Yes.
Okay, and so that can be done under cystoscopic guidance. You can insert the balloon, or you can do under C-arm guidance.
Yes.
And last is endoscopic dilatation
Endoscopic.
under vision.
Okay. So Ojas, which are the number you said? What are the sizes?
So from uh, 6, sorry, 4 to, so actually I'm not sure, sir. I'm not
No,
sure.
4,
6
6
to
from
14.
6 to
6 to 14. 14.
6 to 4.
even 16. Okay.
16.
And which
Okay, sir.
numbers are not there?
Sir, don't know, sir.
After 12, there is no 13, 12, 14, and 16.
Okay.
Okay.
Yes,
So
sir.
this,
Yes,
yeah,
sir.
these are the different numbers which are available. So what are the complications you can create with this?
So forceful dilatation can cause false passage and mainly false passage, sir. False passage and injury to the ureter. And also later on, mucosal injury can cause ureteric strictures in the long term.
What are the grades of ureteric injury?
Sir, grades of ureteric injury, sir, one is first is the AAST classification. The other classification systems are TULS classification. In the AAST
Okay.
classification, grade 1 is just mucosal erosion or just petechia. Grade 2 is uh, transaction. Ball injury less than half the circumference. Grade 3 is more half to full, but without a loss of length. Uh, uh, Grade 4 is there is complete avulsion and there is loss of less than 2 centimeter loss of length, and one last is complete transaction with more than 2 centimeter sir, gap.
Very good. So this is your classification of ureteric injury.
Yes,
So related to URS, there is endoscopic classification.
Endoscoping, yes, sir.
Yeah.
Sir,
TULS, sir.
So in
Yes, sir.
endoscopic, you have mucosal injury, then
Yes, sir.
muscle deep. Second is grade 2 is muscle injury.
Yes, sir.
Grade 3 is that you have perforated the ureter, and
cirrhosis.
fourth is the avulsion.
Yes, sir.
Was two small questions. What is the
Yes, sir.
passive? What is the passive dilators?
Sir, passive digest and ureteric catheters are the passive dilators, sir.
Okay. What is the width of balloon on inflation? Width
4 to
and-
5 mm. 4 to 5 mm, sir.
And length?
Length is sorry, sir. Length is yes, sir. Length is 5 to 6 centimeters.
So it is a 5 mm width and 5 centimeter. Five number. You remember 5 number. Width
Okay.
and length both is same.
Correct.
In collapsed state, how much is the size of that at the site of balloon?
2 to 3 mm, sir.
Size of ureter, that catheter, balloon catheter, at when it is depleted, what will be the size at that place?
Around 5 French, sir.
You can tell it as a 5 French. The range is 3 to 7 French.
Okay, Rajesh, I want to ask you one question.
Yes,
Which cystoscopy means how will you do dilatation?
sir. I mean, so ureteric dilatation, sir.
Yeah, you want to do ureterinoscopy
Yes, sir.
and you want to do ureteric dilatation. How will you go?
Sir, after proper positioning of the patient, we'll do a cystoscopy first, sir. After doing a cystoscopy,
So
we
for
will-
a cystoscopy, which sheet you will use?
sir, normally we will use 20 French sheets, sir.
So if you use 20 French sheath, now
Yes,
how
sir.
will you do dilatation?
Sir, after doing the cystoscopy with the 20 French sheath, we will put a guide wire through the ureteric orifice, sir,
Yeah.
and we'll remove the scope, sir. We'll remove the scope along with the sheath, sir. And over the guide wire, we will made a sequential dilatation after
So,
proper lubrication, sir.
so from the cystoscopy, you will not put any dilator.
Yes, sir, we can put, sir. We can remove the telescope, sir. And through the sheath also we can put, sir.
So with the telescope, which are the
With-
dilators that can go?
Sir, 6 French can go, sir. 6 French can go. 6 French and 8 French also can go, sir. If we will put a sheath of 22 French, then 8 French can also go, sir.
20 is 8, and
Yeah.
otherwise, with a 25 French sheet, 10 number,
Yes, sir.
10 French. Okay.
Yes, sir.
Now you will remove the sheath also, or you'll keep the sheath?
Sir, sir, we'll remove the sheath, sir.
Which is better? Okay, I will ask that
So
question too.
better to keep the sheath, sir.
So with the sheath and without the telescope, from 22 French, which size of dilator will go maximum?
Up to the maximum, sir. 14 French
Which
can
one
go,
will
sir.
go? 12. And with 25, maximum is 14. Without
Yes, sir.
telescope, you cannot go. So
Yes,
more
sir.
than that. So normally, if possible, we
Yes,
like
sir.
to do it with a 25 French sheath if
Yes,
the
sir.
urethra is very accommodative. Because with the sheath inside, we are able to do dilatation up to 14 French.
Yes, sir.
Okay.
Yes, sir.
Okay. So if you don't have sheath in the place,
Yes, sir.
and if you have got a sheath in the plane in your urethra, what are the advantages?
Sir, if we have a sheath in the place in the urethra, sir, the first thing, the trauma to the bladder neck is minimized, sir, while putting, and there will be no kinking in the guide wire, sir.
Very good.
And the third, the procedure will be fast, sir. The fourth is mm, sir, that much I can.
So
The direction.
angulation of the bulbar urethra and elevation of the prostatic and bladder neck is straightened by placing the sheath.
Yes, sir. Yes.
Okay, and that sheath
Yes.
is the fulcrum effect. If you try to pass the dilator without sheath, then you have to use more force, and there is a kinking at the level of bulbar urethra, probably.
Yes.
So
Yes, sir.
that is avoided by placing the sheath, and the sheath is act like a fulcrum through which that ureteric dilator goes directly to the ureteric opening, and whatever force you are applying is directly getting applied to that ureteric opening and above only.
Yes, sir.
So the chances of dilatation and introducing this dilator inside the ureter are very high. Without sheath,
Yes, sir.
you may not be able to enter into because you are not knowing, na?
Yes,
And
sir.
this
Yes.
you can do under CM guidance.
CRM guidance.
Fine.
Another question: what is the name of routinely used single step active dilator, its sizes and length?
सर नैलेटन डायरेक्ट
हमारे पास routinely वही यूज करते हैं
सर नैलेटन
ureter के लिए नहीं. I use it for urethra.
Yeah, you answer, Rajesh.
सर नैलेटन डायलेटर सर नैलेटन
No. Suraj has replied in the chat box. It is Nottingham dilator.
Nottingham.
यस यस नॉटिंग
Okay.
So it is a 6/12 or 6/14.
यस सर
Yeah. Same as your PCNL. Screw dilators. Yeah. Next. Paras. See carefully, properly. Dr. Hudedar, you want to ask any question, please? You can ask them. Huh?
Boloji, it is not so difficult. What is this?
So this is an flexible ureteroscope. The
What type of flexible ureteroscope he is showing you now? There are some points which can make you identify what type of flexible ureteroscope it is. Are Baba digital
It's
and
intuitive.
fiber optic?
digital,
It's
yes,
intuitive,
sir.
sir.
It's a
Intuitive
digital.
flexible ureteroscope.
So why is it digital? From this,
Because
the way
in the conventional, sir, there is an eyepiece and not an attached cable to this.
not conventional, you should call it fiber optic. So in the
Fiber
fiber
optic.
optic scope,
Fiber optic.
there is a camera attachment and a light cable.
Yes, sir.
Here, this is a CMOS tip. There is a CMOS tip. At the tip, there is a CMOS chip.
Tip on the tip, sir.
Yeah. So this is a flexible ureteroscope which has a built-in camera and light source. Right?
Yes,
So
sir.
this is a digital scope.
Yes, sir.
What are the different
So,
types of flexible scopes which all companies are making?
so Stores is making, Wolf is making, and this Olympus is also making it.
So do you know the names of any of these scopes?
In the this stores, we have an fiber optic as well as digital. The names are Flex X, Flex X2, and the digital one is the Flex XC. And in the Wolf,
So the
Wolf
digital is a
also
Flex
making
XC and the fiber optic one is a
fiber
Flex
optic are
X2,
the, sir, and
Flex
X, sir.
X2S.
S.
Okay. What are the
Yes, sir.
differences apart from the vision? What else is the difference in that? The working channels.
Working channels, sir.
Okay. Yeah. So one is the fiber optic is at 3 o'clock and the Flex XC is coming at 9 o'clock position.
9 o'clock position. Yes, sir.
Yeah. Okay. So can these working channels, the different position of working channels, can it be beneficial? Would you like to have
Yes,
both
sir.
the scopes in your armamentarium? Why? In which condition it is beneficial?
Sir, working channel, sir, we can use on the left and right side.
Correct. Correct. So
If we are
sometimes when
doing
the
on
stone is in the lower pole,
yes, sir.
and sometimes you can see the stone, but your laser fiber is not able to reach it.
Yes,
In
sir.
that situation, you may use the opposite scope, wherein the working channel will be, for example, at 9 o'clock position, and you are in the
left
in the
lower
correct.
helix.
Yeah. So then it will reach the stone, right?
Yes, sir.
So any other companies you know? Which are the other companies making?
Wolf, sir, is also making the fiber optic.
So Wolf
Cobra.
has Wolf, Viper, and Cobra.
Cobra and Viper, yes, sir.
Yeah. So Cobra
And
has advantages
digital
that
one
it
is
has.
bow, sir.
Yeah, correct. Wolf Boa. So in the Cobra, there is a advantage of two working channels. So
Two working,
yeah,
2.4 and 3.2,
correct,
sir.
correct. So you can use the basket and laser fiber together. But the trick which I told for ureteroscopy, the same trick can be applied for flexible. So if you use the
Yes,
correct
sir.
size basket, you can also use a 200 micron fiber in any of the scopes. So what is the working channel of the flexible ureteroscope?
3.6, sir.
Correct. So if you use a 1.7 French basket and a 200 micron fiber, both can be easily accommodated.
Use it together. Yes, sir.
Yeah, yeah. So, and which is the third company now making the scopes?
Third is the Olympus, sir. They
Yeah. So
made
what
the
is
UFS.
difference with Olympus?
Uh,
URF P7, correct?
yes, sir.
URF
UFS
P7. But
P7, yes, sir.
what is the digital scope called? And why I'm asking that scope?
In Olympus, sir.
Yeah. URF V. What is URF V?
V1 and V2, sir. V.
Yeah, it is the digital scope from Olympus. The advantage with that is the NBI, narrowband imaging.
Okay, sir.
Okay, so you need the Olympus trolley. The NBI comes only with the Olympus system. So when you have NBI, you can use the digital flexible ureteroscope to do upper tract surveillance. If you have some unexplained hematuria, and you want to, if you have some suspicious mucosa, you can use the narrowband imaging, wherein the green and the red light is absorbed by the red blood cells, and they will appear more darker. So that will help you take the biopsy. Do you know the kind of biopsy forceps that are available for flexible ureteroscopy?
Not seen, sir. No, sir.
So there are two types of flexible biopsy forceps. One is from Cook Urology, which is called bigopsy. But the problem with that bigopsy forceps is that it is a backloading forceps. So you have to backload it. You have to get the flexible out from the tip of the
Distal
ureteroscope. Yeah, you have to backload it and then attach the handle. But when you are going in, you have a big forceps right in front of your eyes. So it is not a very practical forceps, and it is quite bulky. And the other forceps which is used for biopsy is a flexible forceps, like our cystoscopy digest and removal forceps. It is a flexible forceps, and it is from Boston Scientific. It is called Piranha. It is a 3 French forceps. So therefore you need a irrigation system. Otherwise you will not have any water pressure inside. So it is called Piranha.
Yes, sir.
Okay. Now,
Yes,
what
sir.
is the difference in the vision between a flexible fiber optic and a digital scope?
So the resolution is 10 times than the
Correct. And then you have
fiber
something
optic.
called a Moir effect. So therefore you have to honeycomb appearance. So to reduce that, you have to activate the filters. There are 2 filters, filter A and B. So you activate filter A, which is for flexible,
Filter.
and filter B is for small scopes.
Yes, sir.
Okay. What are the deflection? Now, can you see Paras is holding that?
Sir, deflections, we have the active deflection
Yeah.
and the passive deflection. In the active, we have the primary and the secondary deflection.
Okay.
So
What do you
the
mean by secondary deflection?
secondary is this secondary is proximal to the tip that we have inflections.
So what happens is that when you are in the kidney and you have deflected, but you are not able to reach the lower calyx, if you give a gentle push and continue to deflect, the stem of the ureteroscope will give you a passive deflection against the wall. Okay, so
Wall. Yes.
against the wall of the pelvis, and it will go down further. So that is secondary active deflection. Almost up to
Yes, sir.
130 degrees can be achieved.
Yes.
So 270 degrees is the deflection, and you can passively deflect it further.
Yes, sir.
Okay. So what are the types of movement? What is macro rotation and what is micro rotation? So macro rotation, macro is you're holding the ureteroscope in your right hand. Okay, because you're a righty. So that is
Yes,
you're going to rotate your wrist. That is the macro rotation. And with your left hand, you're going to do in and out movement of the scope, but in a difficult situation. With your left hand, if you rotate the scope a little bit, you will get micro rotation. That is called micro rotation. Okay. Do you know what
Yes,
is
sir.
a logic scope and an anti-logic scope?
Sir, logic scope is the up means the deflection upwards and the down means deflection downwards. It is an American.
Anti-logic
Yes,
is
sir.
opposite. Correct.
Anti-logic
So
is opposite.
So somebody asked Professor Traxler that why Europeans use anti-logic. So his answer was that Europeans think that when they are going up the ureter with a semi-rigid scope, they are going down and the ureteroscope is going up. So therefore
Yes,
they use that anti-logic system, whereas the Americans are using the logic system. I think most of us are used to the logic system. That means up deflection is up and down deflection is down. Okay.
So
Another thing
sir?
so there is a logic and an anti-logic scope, right?
Yes, sir.
So logic means up. When you deflect the lever up, it is going up.
Yes, sir.
When you deflect the lever down, it is going down. Okay.
Yes, sir.
That is the American system. It is also called the American system. So the
Yes, sir.
logic is the American system, and that is what most of us are using.
Yes, sir.
Okay. The anti-logic scopes are when you deflect the lever up, the scope is actually deflecting downwards.
Yes, sir.
So that is anti-logic. That is the European system. So somebody asked Professor Traxler that why Europeans are using the anti-logic scope. So he said that when you're doing URS, when you're doing a normal URS, you're putting the URS down and going up the ureter. Na? You're
Yes, sir.
moving your scope down, right? And the
Yes, sir.
ureter scope is
Yes,
going
sir.
up the ureter.
Yes,
So
sir.
that is the logic they use. So as an anti-logic, so they say that when you're going down, it should go up. So therefore, they are using the system wherein they deflect the lever down and the ureter scope goes up.
Okay. Yes.
That is the anti-logic. Okay. So
Yes, sir.
all these companies have got different position of working channels. You must just know for your knowledge that like Wolf comes at 2 o'clock, ACMI comes at 6 o'clock, Olympus comes at 6 o'clock, and Carl Stores comes at 3 and 9 o'clock positions. Okay. So what
Yes,
are the accessories used for flexible URS? Just name the accessories.
Basket, sir.
So whenever you have to answer such a question, you should go in order. So first you will do URS, right? So you need a guide wire.
Guide wire.
Okay. So what are the types of wires available?
We have answer Terimo guide wire, Zebra
Correct.
guide wire, bi
If you
wire,
want a combination of these two, what is it? What is
bi
bi
wire.
wire?
Bi wire, the
So
both the ends are floppy, sir.
that is not the only thing. There is one more quality. It has the quality of a zebra wire also.
Yes,
That
sir.
means the core
Yeah.
is made out of nitinol.
Nitinol and the outer is the PTFE coating.
Correct. So it is called a hybrid wire. Okay.
Yes,
So
sir.
there are several types of hybrid wires. There is a Boston Scientific called the sensor wire. There is high
Sensor,
wire.
yes.
Yeah, there is high wire and bi wire. Now high wire is not available. Bi wire has got both the tips are flexible and both the tips are soft. So what is the purpose of having two tips of soft end?
Sir, so this proximal end would be in the we will put
In
into
the body when you are
kidney.
introducing, so there is no
Yes, sir.
perforation. Okay.
And the back end
distal
will
end?
will backload into the scope.
Very good. So when you're backloading the scope, you don't want to damage the channel. So therefore, you must try to hold the scope straight and then backload it. And that wire can be sometimes very stiff, like a zebra wire can cut like a knife. So it can damage your channel. So therefore, you use a bi wire. Okay. So
Yes, sir.
basically, it's nice to have a hybrid wire so that you don't need a combination of a glide wire as well as a zebra. So you don't need
Zebra.
two wires, so you can reduce your inventory. So therefore, you have a hybrid wire. So hybrid wire is sensor guide wire from Boston Scientific and bi wire from
Bi wire.
Cook.
Cook.
Okay. Then what is the next accessory? After doing ureteroscopy, you will introduce
Ureteric access sheet.
access sheet.
Access sheet.
So suppose you're doing, most of the people performing flexible URS are not keeping a safety guide wire. But just in case you want to use a safety guide wire, do you know any methods of keeping a safety guide wire? So now we don't use double lumen catheters, but in the past we used to have double lumen catheters wherein you can introduce a safety guide wire. Okay, and now Cook Urology has come out with an access sheet which is called a flexor pass. Flexor pass. So the access sheet works in such a way that you put a normal guide wire. When you're pulling out the stillet, the guide wire goes. So when you're introducing the access sheet, the guide wire is coming through the stillet, but it is going outside. It has a small device which takes the guide wire outside the access sheet. And then you introduce the access sheet. When you take out the stillet, the guide wire remains outside the access sheet. So in that way, you can have a safety guide wire. So next time, if there is some time, I'll show you a small video how that flexor pass access sheet works. So today, I have not loaded my presentation. So next time, I'll connect with the laptop and show you the presentation, how the flexor pass access sheet works. Okay. So second accessory is your access sheet. So access sheet can be of different types or different companies make access sheets. So you must know the commonly available ones, the Cook Urology, that is 9.5, 11.5 and length is 35 and 45 centimeter. And you have 10.7, 35 and 45 centimeter, 10.7 by 12.7 and 12 by 14, again 35 and 45 centimeter. Now suppose if you have a pediatric patient, which size access sheet you will use?
13 centimeter.
13 and 28. There are two.
28.
So 13 also and 28 also.
Yes,
28 is used in which patients?
female. We can use.
No. Anatomical abnormalities like ectopic kidney, horseshoe kidney, wherein the kidney is low lying. Okay. So you may
Yes, sir.
use 28 French access sheath. If there's a ectopic kidney and you're doing flexible URS, you may need 28 length access sheath. Okay, so
Yes,
Cook
sir.
makes these flexor access sheets. Then Boston Scientific makes Navigator, and there is access sheet also by Roccomed. Okay, so you should just know the names. Then next accessory is
Baskets.
Baskets.
the port seal. Port seal. So when you attach the flexible ureteroscope, you need the port seal, which can help you lock the laser fiber. And also, can you see this? Zoom in into this ureteroscope, which Paras is holding in his hand. Just below his little finger, you can see that port seal. Okay.
Yes.
Yes, sir.
So this is a port seal which can help you lock the laser fiber and also lock the baskets.
Yes, sir.
Okay. And also
Yes, sir.
prevent the water from coming out. So this is the third accessory, port seal. Then fourth is irrigation system.
Irrigation.
Okay. So simple irrigation system is you take a TURP set, attach a pathfinder and take a 100 centimeter extension. So whenever you want some irrigation, your assistant can help you, give you some extra fluid in the system. Okay. Then you
Yes,
also
sir.
have a Cook irrigation system, which comes with a built-in chamber, which allows the airlock and does not allow air to go in. So it comes with a chamber which is like a pathfinder. Okay. Then you have a self-filling syringe, which is available from Boston Scientific. Okay, so it is like a syringe. You press the syringe and the spring action fills the syringe again. Then again you press it, then again the syringe fills up like that. So you have that also from Boston Scientific. And the fourth type of irrigation, which is used in cold countries, they have not only the speed of the irrigation, but they also control the temperature. Okay, so in cold countries, you have more complex irrigation systems which heat the fluid or keep it at body temperature. Okay.
Yes, sir.
And the last accessory we already discussed, the biopsy forceps. Okay.
Yes, sir.
Yes.
Now just one small word on laser fibers. What are the parts of the laser fiber? Okay, Paras is showing us the laser. Okay. So what are the different modes of laser?
Sir, we have one is the fragmentation,
Correct.
dusting.
Basically, what are the settings? So what are you in the past? What were we selecting? We were selecting frequency and energy.
Frequency and energy, sir.
Yeah. So now
So
what is the change in the newer machines? What has happened in the newer machines?
they have, sir,
What
fixed
is
setting.
why? Why have they fixed the settings?
Because, sir,
So what is the new parameter which is important? Is it the fragment? Is it the energy and the frequency, or there is a third parameter which is most important? The third most important parameter right now is the pulse width. Pulse width. So these people think urologists are stupid, but we are not stupid. We are smart people. So they have fixed the pulse width settings in most of the machines. So for all different kinds of modes, whether it is dusting, popcorning, fragmentation,
painting.
whatever mode you select, everything is long pulse. Only one
Yes, sir.
mode, which is fragmentation, is like a short pulse. Okay. So fragmentation means it is using all the energy and giving one short beat. You're using all your force but giving one doom and it breaks the stone.
Hmm.
So that is a short pulse. So except for fragmentation, every other mode is long pulse. So that is one way you
Long
can
pulse.
remember that. Okay, you can remember that. So this is all pulse width setting. So you should remember that these modes that they have given is all pulse width setting. Now, what are the parts of the laser fiber? So there are three parts. One is the silicon core, the silica core.
Silica
Okay,
core.
that is that is the fiber. Second is the cladding.
Cladding.
Okay, and third is the jacket. The blue
Jacket.
that you see is the blue that you see is the jacket. So which part of the laser fiber is protective?
Jacket, sir.
No, that is the mistake which everybody thinks, that jacket is protecting your scope. Jacket has no role except for identification. So
Okay,
in the past, everybody was stripping the laser fibers. In fact, all these laser machine came with strippers. But now the new thinking is do not strip your laser fiber because you want to identify it and not damage your scope. So the new concept is to cut the fiber flush with the jacket using a scissor and not use a stripper. Okay,
strippers.
correct. So no using stripper, just use
Scissors to cut it.
the scissor. Correct, correct. Okay, so that jacket is only for identification. It is not going to protect it. So are there any new generation fibers which can, suppose you are in lower calyx and you want to introduce the fiber, how you can introduce it? Normally you should come out, right, and make it neutral position and introduce the fiber. But suppose there is a difficult anatomy and you want to introduce the fiber in the bent position. Can you do something to introduce it? So there are new fibers which are called ball tip fibers. So they don't have the sharp end, they have a ball tip. Okay. So therefore you can introduce the fiber in a bent position. Now
Bent
outside the fiber box, it is written 1x or 10x. What does that mean? 1x means it is a single use fiber. It is length is only 1 meter, and 3x is a multiple use fiber. Its length is 3 meters. Okay. So every
Yes,
time
sir.
you use the fiber, you are actually supposed to cut out 10 centimeters. But none of us do that. We only cut out little bit part of the tip. Okay. So ideally they are saying recommended is to use the 10 centimeter cutout. Therefore they are giving the 3x fiber. Okay. So what happens to the tip of the fiber? Why you have to cut it out?
Because the blue jackets are basically once
No,
we do.
nothing to do with the jacket. Jacket is nothing. It is just a protection. So fiber burn back occurs. Fiber burn back occurs. So everything is the bubble. You know what is Moses technology? Na bubble. So there is a bubble which creates this
Cavitation,
energy,
yes, sir.
cavitation bubble. So that
Yes,
energy,
sir.
na, that is destructive. That is what is destroying the scope. That is what is destroying the stone. That is what is destroying the laser fiber. So it is all about the bubble, okay, and Moses technology. So you must read the Moses technology and the laser tunnel. These two things you must read, okay? Then we can discuss next time. What is laser tunnel? What is Moses technology? Okay, Paras, next slide.
Yes, sir.
I think it's over.
Okay, so I think, sir, a lot of information on
Yeah,
flexible.
lots of information
Yes,
you've
sir.
given. And
Yes, sir.
I'm sure that if they listen to this clinic again,
Yes,
they
sir.
will remember Mesmer, everything
Yes,
they
sir.
will. So very good. Thank you very much, Hiren.
Anytime, sir.
And
I have
Dr.
some
Hiren is,
presentations, so anytime if they want, sir, I can
yeah, so
take
next time we will
full.
see
Yeah.
what is left
Okay, sir.
behind and
Yes, sir.
we'll decide. Okay, we'll ask
Yes,
them
sir.
on the group. During that
Yes,
time, you
sir.
can just, initially you can give your presentation.
Yes, sir. Yes. Yes.
Right. Okay,
Good night,
okay.
everybody. Good night, Gite sir.
Good night,
Yes,
Thank you so much,
Rajesh,
sir.
Thank you, sir.
Yeah, yes, sir.
Rajesh, you are not afraid now, no?
Yes, sir. No, not afraid, sir.
So you tell your friends also, okay? Whomever is, so just
Present. There's
it
so
will
much
be good for them.
opportunity here. Sir is right, Sir is giving you all so much opportunity. Please take it. Gite sir is there. Gaurang Shah sir is there. Don't be scared. Make mistakes here. No problem. Well done, Ojas. Where is that fellow, Abhishek? He's hiding today.
Abhishek is not well today.
Oh, okay.
That's right.
Okay.
Okay,
Okay,
okay.
sir.
Good night, everyone.
Thank you, sir.
Good
Thank you,
night.
sir. Thank you,
Good
Gaurang.
night,
Thank you, Gite sir. Thank you, Hiren Sodha sir. Thank you.
Thank you. Bye bye.
Thank you.
Bye.